Hey guys, welcome to today's James Clinic Team Education. We want to talk today about hyperbaric oxygen. And first thing, we're going to cover a number of things about hyperbaric oxygen in our office and then the comparison of the other types of hyperbaric. So we are going to go through the difference between hard chambers and soft chambers. What does actually hyperbaric oxygen do in the body? And let's see, I'm going to do this. What does it do in the body and what are the physiologic effects? Who should be doing this clinically? What does it cause? We will very briefly review the gas laws because I hate physics. And then we'll talk about the practical stuff. We'll talk about what do you need to know to put somebody in a chamber? What are kind of some of the best practice things that we have figured out in doing this now for 3 years? So just a little bit of background. People who are in this space, I'm from the Paul Harch our hierarchy. He's one of the researchers out of New Orleans. It did a lot of looking research into this, how it benefited patients. So I'm kind of that lineage. And they had approached me in the summer of 2021 about getting involved in hyperbaric medicine. And at the time, I was in the ICU, things were falling apart, and I didn't know, like, what is this about? Do you want me to sell chambers? Do you want me to treat patients? Do you want me to do something? Like, I didn't understand the cause. And then some of you heard the story about my brother. He got really sick with COVID in October of 21. I had treated him with early treatment with COVID. He was at the time 350 plus, 6 foot-pound, 40-year-old male. We put a lot of those in the ground. And so I took it really seriously. We got him started on early treatment. Despite that, around day 8, he did what all the guys do. He dropped his sats into the 70s and 80s. Took him to the hospital for the second time that week. They refused to let me go in with him. And he said, I'm not going in without you. I had a look of terror. He doesn't remember any of this, by the way, because his stats were too low and he was pretty gray. So we went back home to our hometown in Sheraton. Nice thing about small towns is we called the person, we got oxygen in the car, and we drove 5 hours to Okoboji, where our friend, Dr. Brad Meyer, brought his hyperbaric chamber from his office. He has a center there to his lake house, treated my brother, showed me how to do it. We bought the chamber, brought it home in the back of my car. 4 days later, my brother was off of oxygen. A week later, he was back at work. About 6 weeks later, we kind of compared his case to somebody who was in a similar boat to his, kind of the same age male, same body type, sick around the same time. That gentleman was in the hospital with a trach and a peg and on the ventilator still. This was in our rearview mirror. So it really showed me the power of hyperbaric medicine and forced me to jump into it. So that's kind of how James Clinic got started. We put chambers in our office in Sheraton. That was our first physical location. We figured out that when somebody came in crashing with acute COVID, this was during the Delta strain, so we're not seeing it as much at all anymore. About 10 hours in the chamber, and we would get them off of oxygen and they'd be back to work. Whether they did that twice a day, once a day, however they broke it, it took about 10 hours in the chamber. So we got pretty good at that. So as we look at hyperbaric oxygen therapy, we call it HBOT in the office just for shorter term. So we actually have soft chambers. Those are considered home units. So if you look at the FDA and their device classification, you have to be over 1.5 ATA to be considered a medical device. Anything under that is considered a home device. So you notice on our units, they have zippers. You can zip yourself in at home and you can control everything from the inside. That is because it's made as a home unit. And we do have those available to purchase if somebody wants one in their home or their gym or for their team. The difference between the hard and soft chambers. So the hard chambers can do the low pressure, but they can go up to, and I don't know the max pressure. I don't think we go much over 2.5 ATA, and I'll talk about what that means. I've stuck to the soft chambers. It's a lower price point by about 10-fold, and it's much safer, much easier to use, and we're still getting good clinical results and makes it a lot cheaper for the patient as well. So it's about a third of the price or less for patients to do the soft chambers versus the hard chambers. So some people call ours mild hyperbaric air therapy. We just still call it HBOT because that's a whole, like, who wants to explain all of that? So our chambers actually do go to 1.3. They have a modified unit now that can go to 1.4. That's a little bit more expensive. We do not have the 1.4s yet. And then again, once you get to 1.5 and higher, you're looking at medical devices. These are now going to be considered insurance-based, FDA approved, and are going to be potentially covered by insurance. Now, I do want to cover really quickly what's covered by insurance and what is not. There are about 14 FDA approved indications for hyperbaric oxygen. One of them is carbon monoxide poisoning, osteomyelitis, chronic wounds, radiation colitis is a big one. So they're pretty specific in kind of the ortho and wound realm. The sad thing is it's not approved until they have about a stage class 3, class 4 wound, and then it's approved for 40 treatments. So I'd really like to see what that would do at stage 1 or 2, and you'd only need a few. So it's still kind of corrupt in my opinion. We have patients that have done the 40 rounds and all of that. And if you guys have questions, feel free to interject as we go. So that's kind of the hard chamber versus the soft chamber. The hard chambers, again, a formal medical device, they have uniplace chambers, which are for one patient. We have something similar to that next to us in Wildwood. That's part of Wildwood Integrative. They have 2 hard uniplace chambers. And then there's something called a multiplace chamber where it's like a room and you can have more than one person in there. And generally you have a nurse or a healthcare professional in there with patients. So at big academic centers, they can bring, 6 patients and they may each have a separate indication. And then you have a nurse that goes in. When you get into those higher pressure chambers though, now you have to look at dive tables and you have to figure out how long they've been under, what pressure they've been under to, how slowly you have to bring them up, and then what do they have left to do recurrent dives over the day. So that you really have to be familiar with that. With the soft chambers, we don't have to worry about any of that. We don't take them deep enough that changes anything. So, the bends, obviously the bends is an FDA approved indication. So what actually does the soft chamber do for our patients clinically? So 2 things that we can easily say, this has been proven in studies, it's published data. We can make these claims all day. Number 1, it's anti-inflammatory. So any condition that is an inflammatory based condition is a potential target for hyperbaric treatment. The other thing it does is it boosts stem cells. So it's going to go in and reactivate those healing mechanisms of our bodies, so that it can start to repair itself. So that makes it pretty perfect for anything like wounds, which we've seen this summer. We've had a couple injuries within the clinic, and we've seen much expedited healing based on that. Skin issues, so superficial lesions, we're looking at it for aesthetics and where that might have a role with the facial cosmetic things. Sunburns, bone healing. Obviously, we've had a couple of fractures. Neurologic conditions, it can be really helpful for people with brain fog. We had a patient come in a couple of years ago. He had acute COVID. When he presented to our office, we were under the assumption he was severely autistic on the spectrum. His brother was, this is an adult male that was around age 50. His brother was bringing him in as a caregiver. The patient didn't make eye contact. He had one-word answers. He was vacillating on his Bible, which was atypical for him. And he was unable to work at his job as a high-level precision engineer. He was unable to drive. He was having panic attacks. This is a 10-mile-a-day runner that quit running because he was having chest pain and would have anxiety. We gave him an IV vitamin infusion and a couple of hyperbaric treatments. And within 2 days, he moved back home, started driving himself again, and came out of his shell. He was not autistic at all. He was a high-performing professional. That was just the spike in the brain causing inflammation, and it turned around that quickly with our interventions. So pretty cool to see. COVID lung, obviously people with acute COVID did well. People with long haul that have persistent respiratory issues, we're seeing them improve. I have patients that have been struggling for years. We put them in there over a series. It's really patient dependent. I don't think there's any formula that so many hours in the chamber, we know they'll get better. But the more densely they do it, the faster they'll see results. So they'll see results after each one, but then there's an accumulative effect as well. It definitely is anti-infective. So most things, bacterial and viral infections, don't like oxygen. So any kind of infections, it's a good thing. Um, does it have a role in cancer therapy? We think so. There's a question, does the soft chamber have enough oxygen drive to support recovery in cancer patients, or do we really need to use it in the hard chamber? I think that's a good clinical question. And then we obviously have developed a really good pre and post-op. Now, or I do not use this for pre-op in our patients. So when you put someone in the soft chamber, you're going to get an increase in oxygen for about 30 minutes after they get out of the chamber. That is not going to be sustained. So doing this pre-op is not really going to provide any clinical benefit. If you were in a hard chamber, it increases the oxygenation up to 4 hours. So if somebody was going to undergo surgery and they wanted to do pre-op, they could do the hard chamber and they might get some clinical benefit, but doing it in the soft chamber is not. But doing it post-op in the soft chamber, every day after surgery is going to expedite their healing. We've seen that frequently as well. The other nice thing it does that I've anecdotally experienced is it improves lymphatic return. So when you have a wound, we had a young lady with a dog bite on her face, like right here on the zygomatic arch. The dog had fallen off a cliff. You guys have probably heard the story. The dog had a spinal cord injury. She climbed down and picked up her dog, and he was obviously in pain and bit her in the face. So she had a big gaping wound here, wanted to come in and get care. So we had her do the IV vitamins, obviously for the wound healing part, and we put her in the hyperbaric chamber. And what happened is that wound shrunk down to a big scab. And I said, don't pull that scab off, just let it do its thing and fall off naturally. She healed with no scar on her face. And she's a 20-year-old beautiful girl. But also, when I found out what happened to her dog, I said, bring your dog in and we'll treat your dog. He can sit in the chamber with you and let's see what happens. The dog was dragging his back legs. So they had a sling under the back legs and were carrying him. He could walk his front legs. So it wasn't completely paralyzed, but he was pretty damaged. So I don't know if it was a bruise on the spinal cord or what. Within 4 to 5 treatments, he was walking without the use of a sling. So not only did it help her, but it helped her dog recover as well. So there is a huge potential for doing this in animals. So this is not my strong suit, but we will go, I hated physics, so I'll just lay that out really quickly. So I'm going to go over the gas laws in a very basic way. So Boyle's law says that the more we increase the pressure, it decreases the volume. Okay, this is where we get the concentrated oxygen effect. So if you think about a balloon that's, I don't know, just a regular size helium balloon. And helium's different, so just imagine it's oxygen. Now we double the pressure, it's going to shrink the balloon in half, right? But you still have the same number of oxygen molecules in the balloon. That did not change. So you increase the density of the oxygen in the balloon. Does that make sense? Yeah. So the more pressure, the reduced volume, the same gas bubbles. This is why people get the bends, because as they're going deep underwater, all the air tissue in their tissues gets condensed. So they get used to that condensed. Now, if they come up quickly, that air expands in the tissues, causing bubbles in their tissues, and they have a lot of pain. So that's where putting them in the chamber is going to reduce the size of those bubbles back down for bends and help slowly increase the change so that they don't have that problem. And people have had air embolus, and people literally walk out and drop dead. So, Melissa, welcome. We are going to share this on YouTube. So I know you won't mention patients, but we are keeping this patient non-specific for today. So that's Boyle's law. As you increase the pressure, it decreases the volume, and that's where we get the concentration of oxygen. That's where it increases oxygenation in the body, okay? Charles' law says as we increase the temperature, it increases the pressure. So one of the stories they told us at training is in Boston, they actually had these big, like ginormous vats of molasses in these steel containers. And one summer, you can look this up, it's pretty fascinating. One summer, the temperature got really hot. And what happened is the vats of molasses exploded, and it literally drowned people in molasses in the town of Boston. So historically, yeah. So if you think about it, we don't put ours outside, but we do air condition them, because as they go into pressure, the temperature gets warmer as they sit in there breathing their own air. So we have the air conditioners to kind of regulate that. So we keep them at pressure. So, those are the two main laws that I think apply here. So I'm going to stop there. One of the things that we talk about is ATA. So that's absolute atmospheric pressure. So when you're standing at ground level, so I'm not adding anything to you, right? So you're standing at sea level. There's no pressure down on you. That's 1 atmosphere or 1 ATA. Now, if I go underwater 10 feet, 12 feet, I'm going 1 ATM down, right? But that's actually 2, or that's not 2. That's 1.3 ATA. Even though I'm only increasing my pressure 0.3, you add the 1 from sea level, if that makes sense. Yeah. So as we talk about ATA, it's absolute. You can convert that to PSI. You can convert that to millimeters mercury. You can convert that to all kinds of things, barometrics. But for all practical purposes, we're always going to, however deep, how many atmospheres we're going deep, we're always going to add 1 for ATA, absolute atmospheres. So that's the units that we're going to use. Any questions so far?
Yep,
All
got
right.
one.
I always got a question.
Good.
So that 0.3
Mhm.
is what we gain from the 10 to 12 feet.
Yes.
Okay.
Yeah.
Okay.
So
it
if
seems
you,
like such a little amount though.
it does. So
For 32 PSI, it seems like it'd be higher, but it's not.
yeah.
Okay.
Yep. So 1 ATA, I believe, is like 33 feet.
33.
Yep. So the deepest we're going to take someone is 3 ATA, 2 deep, which is going to be like 67 feet. Now divers go highly skilled divers go much deeper than this, right? But
Okay.
just for the medical applications. And we'll kind of talk about how that changes oxygenation here in just a minute.
Okay. Thanks.
So yeah. So when somebody gets in the chamber, so commercial jets fill the cabin to 1.3 ATA. They just don't add any oxygen. So you're in a low oxygen environment because you're so high in the air, right? But then they pressurize the cabin. So that's why people get tired after flights, because your oxygen level you're exposed to is low. So, yeah, I try to explain to people it's either like flying in a commercial jet, or it's like if you ever did diving for rings, your ears kind of popped as you went down to about 10 feet to get things off the bottom. It's kind of the same idea. So either way. So I am going to get into a little bit of didactics here. I asked everyone to have kind of a blank sheet of paper, and I'm going to kind of draw the graph for those of you in Michigan, that the whiteboard that I had, I'm going to kind of recreate that. Okay. And I wish I had a fancy way to do this on the screen, but I don't. So I want you to draw a graph. And on the left is going to be the PaO2, and on the bottom is going to be the FiO2. So the bottom is going to be from 0 to 100. And for those of you watching on YouTube, I have a room full of ICU nurses here, so they're going to kill it on this, but we're going to kind of go over that. Okay, so what is the oxygen percentage at room air?
21.
21. So I say 20 just because it makes the math a little bit easier, but yes, 21 is correct. So I'm going to create 5 bar graphs here at 20, 40, 60, 80, and 100. Okay. So that's the FiO2. That's the fraction of inspired oxygen is about 21% at room air. Now, if I did a blood gas on any of us here in the room, so you poke the wrist, you draw from the artery, and you check the amount of dissolved oxygen at that level, what is the average PO2 going to be?
60 to 80. 60 to 80?
Close. You're thinking of sick people because we only do it in sick people.
I'm
So it would
thinking,
be around
yay, we got 60.
It'd be around 100 though, right?
Yeah, it's going to be around 100.
Save them. We're at 60.
Yeah. Yep. So for healthy people, it's going to be around 100, and 80 to 120, I think, is the average. But just to make the math work today, so I'm going to create a bar graph here. At 20% FiO2, my PaO2 should be 100.
Got it.
So now at 20%, if it's 100, what if I put the patient on a ventilator and put him on 100%? I increase the oxygen times 5. And I had him breathe pure oxygen. What would their PO2 be?
500.
Yes. Thank
A
you.
lot higher.
So that's your top number on the right. So make this 100, 200, 300, 400, 500. So I'm going to go to the right, and on 100, I'm going to make it 500. So your graph should look like this at this point. Mine's kind of hard to see because I picked the same color here. But so at FiO2 of 100, my PaO2 should be 500 if you're healthy. At 20%, it's going to be 100. So if you're a religious person, God's design was pretty good. He gave us about 5 extra capacities in our lungs so we don't die if we get lung disease or sick. So now if you're if you're at 40%, what should your PaO2 be?
200.
Yep, 200. So I'm just going to make bar graphs on each of these to represent this. At 60%, it should be
300.
Yep. And at 80%, it should be
400.
400.
400. Okay.
That's so pretty.
So this is what your graph should look like. So at each increase in FiO2, this is what your PaO2 should be on a blood gas. Okay. Now we haven't even talked about oxygen saturations, right?
Right.
Because a PaO2, unless you get under 60, your sats should be 100%. This is why we failed during COVID, because everybody was looking at the sats and the sats didn't matter. Because we're not even on, the sats are way below this graph. Okay. So now what we're going to do is if I put somebody in the chamber on room air and I increase the pressure by 30%, what should be the increase in PaO2?
300.
PaO2. Say that again.
If I take someone at room air and I just put them in the chamber with no extra oxygen, what should the increase in my PaO2 be by increasing the pressure by 30%?
Don't know.
Anybody else have? So 30%. So you're going to go from 100 to 130. Exactly right, Christy. Yeah. So I'm going to make a little umbrella here. Sorry. Up 30%. Okay. So now what do we have for oxygen in our chambers? What can we do to increase?
Add oxygen.
Yeah, throw them on some.
How much? Yeah. How much do we have?
Ours is
9 liters.
Ours is set at 9.
9. Okay.
9.
So for every liter of oxygen you add, how much FiO2 do you gain?
30.
How much FiO2 do you gain for every 1 liter of oxygen? You're close.
We're close to 30 per each.
3% per liter.
Oh,
So if you put someone on, yeah, if you put someone on 2 liters, you're going to go from 21% to 27%. So if we put them on 9 liters, we're going to add 27 to 21. We're going to be pretty close to 50%, right?
Right.
You guys tracking?
Yep.
Okay. So at 50% oxygen, what should my PaO2 be?
Between 250 and 300.
Yep. 250. So now if I take someone, I add 9 liters and then I put it under pressure at 30%, 1.3 ATAs, what should my PO2 be?
Ooh,
Hang on, 9
Jane had
liters.
30%.
So 3% per liter, 3, 6, 9, 12, 18. So it's 27. Percent, yeah. I don't know.
You've already lost me.
That's okay. Nope, you're really close. So you take that 250 that we're going to get by increasing the nasal cannula, right? And now I'm going to increase it by 30%. So if you take 250, so 25 times 3, 75. So I'm going to get up to around 325 to 350.
Oh, 25% times 3. Okay.
Yep. So if you look, I'm still not as high as I would be if I'm 100% on a ventilator, right? But I'm pretty far up there just by putting someone in a chamber and throwing a nasal cannula on them. So we're going to increase the amount of oxygen dissolved in the bloodstream 3 times by putting a little nasal cannula on and throwing them in the chamber. Is that tracking for everybody?
Mm-hmm.
So when they ask you what it's going to do, that's what it's going to do. Now,
So what happens when you increase the pressure? Does that release it into the tissues easier?
so that's another question because that gets into the 2,3 DPG, right? And the oxygen release, there are things that shift that curve one way or the other.
Does it pop it off easier?
That's a different discussion. But remember, not all of the oxygen dissolved in the bloodstream is going to be carried on hemoglobin. This is just going to be free oxygen dissolved in the bloodstream. So you're going to get around clots. You're going to get it into the tissues better because it's going to dissolve through capillaries better.
So this is the pressurized oxygen in the bloodstream itself, not necessarily carried on the red blood cells.
Correct.
Oh. Okay,
Yep.
a light just went on. Thank you.
Yep. Yeah, so yes, it gets to the tissues easier because it doesn't have to be released off of a hemoglobin. Because you kick off you have 4 oxygens on a hemoglobin, right? The first one kicks off easy. The second one is less easy. And then it goes from there. And usually you carry the last 1 or 2 back to systemic. Cool. So that's how we get to when I tell somebody I just want to like do the scientific fundamentals of when I tell someone I'm going to increase your oxygen 3 times when you sit in the chamber, I want you guys to know why. Okay. And this tracks back to like ventilators and physiology on the ventilators. I want to divert for a minute before we talk about hard chambers. Okay. So during COVID, did any of you take care of vented patients during COVID? Yeah. Okay. So this goes to the P to F ratio. So do you remember back to the blood gases? So we had people on 100% oxygen. Everybody was. This was a rarity in the ICU. Every single patient was on 100% oxygen. So their PaO2 should have been 500.
Right.
Sherilyn, do you remember what it was on most of our patients?
I can't remember. It was much longer than 10 minutes ago.
It was like 50. Okay. So if you can use this same bar graph to talk about ventilators and P to F ratio. So down here, if you're in this range, this is severe ARDS. This range is ARDS. Because you're losing 90% of the oxygen you're giving them is getting trapped in the lungs, in those sick lungs, and only 10% is getting through. This is why people were dying, because we lost 90% of their lung volume. We couldn't get the oxygen through because their screen if you think of the lungs as a screen, the screens were plugged up. We could not get oxygen through their lungs. This is why they put people on ECMO, to get oxygen in their bloodstream without having to use their lungs. Okay. This is why everybody died. And this is what people don't understand about respiratory physiology. When they say event is bad, it killed everybody. No, the vent was just the tool as they were dying that they got sucked to. So, because they didn't get early treatment. So anytime you have a patient on a vent, this is how we determine if vents can be weaned. Because if I have someone on 60% oxygen and their PaO2 is 100, 200, guess what? I can turn them down and I know how much I can turn them down their FiO2 to wean their ventilator. So this is a really simplistic way of that really complicated physiology, because I got to think about it real simple when I'm rounding in the ICU in the mornings. Okay. So this is about the best we can do with a soft chamber and nasal cannula. So I want to be really careful and really accurate when we talk to people. I don't want to tell people we're using 100% oxygen, because we're not. We're not using pure oxygen. We are using a little, and you don't have to use the nasal cannula. You can just do it at room air too, and you're still going to get enough of a bump. You're going to see a difference. But you can see if you're healing a wound, you're better off to have that air, the oxygen blowing in your face to get a little extra boost. Okay. Now we're going to go to hard chambers. So in the hard chambers, you can give someone 100% pure oxygen. Okay. So I can get their PO2 to 500. But then what do? We pressurize it to 2. What's that going to take their PO2 to?
I don't know.
Is it times 0.3?
Katie, I'm going to get to your comment in just a second, okay? Because it's a good one, and it's kind of goes back to COVID. So I'm at 30%. I'm at 1.3 here, so I'm going to take it times 30%. So if I'm going to double the pressure, I'm going to double the PaO2. What's it going to shoot my PaO2? What am I going to hit?
$1,000?
Yes.
Holy mackerel.
Uh-huh. So this is why the hard chambers are more dangerous, because you can actually get oxygen toxicity. You can get oxygen seizures. Having too much oxygen is not necessarily a good thing. It's a good thing for short times. But this is why when you're in a hard chamber and you're doing 100% oxygen, you have to take air breaks. You have to go back to 21% to kind of drop that PaO2 down so you don't get oxygen toxicity. So that's something we don't have to worry about in our world because we're way down here.
Well, how do you know if they're getting oxygen toxic? Is everybody individual, or is there basically a number that you guys sort of pick?
Oh, that's a really good question. I will try to answer that. There are some things that can make them more susceptible to oxygen seizures, fevers. I believe estrogen therapy is one of them. Anti-seizure medications. What else? Those are the main ones. Little guys can get it faster than big guys. So you put a little kid in with an adult, the kid can seize earlier. So we're not going to do this right now, but if in the future we have hard chambers, this is an exercise, because if you have somebody in a hard chamber that's seizing, you can do nothing. You can't do anything. All you do is turn down the oxygen and they'll stop seizing and come back. So our instinct, if somebody's seizing, is to grab them. You can't grab them in a hard chamber. So you got to know what to do and turn that oxygen down, let them wake back up, bring them out. Because you can't turn the pressure straight down either, right? You got to go gradually so the pressure can equilibrate.
Thank you.
Yeah. Okay. So the question was, if you lay someone prone, that would cause additional pressure to help absorb. I think it's the opposite. So I'm a really horrible artist, and you'll get that in just a second here. So if this is a person laying on their stomach, this is their head up here, these are their lungs, this is their heart. So I think it is more of a surface area problem when we laid people prone, because you have less, so air rises. And if you lay on your back, you have less surface area in the front of your body than you have more surface area in the posterior lungs. So if you lay somebody prone, the air is going to rise. You have more alveoli back here to absorb the oxygen. Where the heart is heavy, so the heart's now laying down and out of your way, so the oxygen can go in a little bit easier. That's the theory I've heard. I don't think anybody really knows. You can talk about secretions and all kinds of other things too, that, we move secretions forward and we open up alveoli in the back and recruit and things like that. That's the best explanation I've heard for it, but honestly, nobody really exactly knows. So, and yes, if you have a low hemoglobin, you're an uphill battle. So they've had some Jehovah's Witnesses that instead of giving them blood transfusions because the patients refuse it, they have gone in and tried to give them hyperbaric oxygen or give them oxygen or put them on a ventilator to get them through it, which makes no sense to me because it's going to be a short-term effect. But speaking of that, they've actually done this in pigs where they've drained pigs of blood in a hyperbaric chamber and the pigs stay alive. And then they transfuse the pigs back with the blood and the pigs recover just fine because you're super saturating it. And if you look back historically, it's really fascinating when you look at the history of hyperbarics, because this all came from diving in the military and the industrial uses, right? Building bridges and things like that. Where was I going with that?
The history.
Yeah. Oh, they used to have operating rooms in hyperbaric chambers when they did the first open heart surgeries, which makes a whole ton of sense to me. And if you're having a stroke patient, they should be going in a hyperbaric chamber, in my opinion. That buys you about 4 hours of oxygenation. Now you can get them to the IR suite or something to pull the clot out, but you've bought yourself 4 hours. If you just dunk them in there, put them at 2 or 2.4 ATA for an hour, you bought yourself some time. So I think it would be really interesting if we could do some research on that, on a bigger perspective, or think about your ARDS patient. If you could put them in a hyperbaric chamber and you like a multi-place chamber and just keep them in there and have the nurses rotate in and out, you could keep them oxygenated while you get their lungs better. So to me, it's just fascinating. The possibilities are limitless. Any questions on that? So if you haven't mastered this chart, watch this again because it'll click at some point. This is how I taught vents to residents, but it really applies to hyperbarics because all we do is take a percentage, whatever percentage. If we're going 0.3, it's 30% increase in the pressure. So whatever FiO2 we're at, we can do the same thing. If we put someone on 2 liters, we go from 20 to 27%. So we're up here somewhere, and then we give them a 30% bump. So now think of altitude and altitude sickness. We're actually going to drop from 20 to 14%. So if you go up to about 5,000 feet, it's 5,000 or 10,000 is 14% FiO2. I think maybe it's 10. This is why you get altitude sickness because it's a lower PaO2 that you're getting.
I've had that. That was fun.
Yeah, it's a good
They
time.
put me on oxygen. Yeah.
So I'm just going to wrap here with a couple of practical tips that we've kind of learned over the years. Where did it go? Oh, here it is. So first of all, always have the patients pee before they go in. The hyperbaric revs up the metabolism, so they have increased renal blood flow. They make urine, so that's usually the limiting factor of how long somebody can stay in. Our times of doing it is anywhere from 60 to 90 minutes at pressure. You can sleep in it. Again, it's a low enough pressure. You could spend 24 hours in it. It's not going to hurt anything. If you go in a deep chamber, you're going to get sick. You're going to bend people if you bring them out after, so you put somebody in a hard chamber for 24 hours, you bring them out, they're going to bend. You can kill somebody. So you can't do that with our chambers. We always try to book the hyperbaric first and the IVs after. We don't want to fill them up with fluid where they have to pee and then put them in the chamber where they can't. So we try to logistically do that just out of comfort. If you have a bottle of water, we only allow water in the chambers. We've had people bring in smoothies and then they spill them because the chamber rounds as it fills up. So you don't have a flat surface to put it on. It's really easy to spill drinks. Make sure you pop the water bottle so that it can equilibrate the pressure. If they put the cap on and seal it, and then they come out of the chamber, it can pop them in the eye, the cap when they pop it off. We don't allow a lot of electronics in because if you think, we do allow phones just because we're practical. You would take a phone on a plane, but that pressure changes the pressure on the battery over and over and over again. Same thing with any other electronics. So just not safe for those. We allow phones for adults. We allow tablets for the kids just to keep them distracted. Anything battery operated, I would leave out. Anything flammable, I would leave out. So oxygen is combustible. So if somebody were to take a lighter in there, it's an oxygen-rich environment. So we have to be really careful of that. So no candles in the clinic. We don't use essential oils because that can increase flammability. So no essential oils around there. Make sure the patients don't take any vapes or lighters into the chamber with them. So you kind of frisk them down. One of the creepiest things, the guy who trains us, and I hope we get a training soon because he's super cool. He's done everything everywhere. He's just amazing. At one of the places, they had a patient in the hospital going in for a hyperbaric, and they're in a hospital gown. So they kind of lifted him, you know, hips from one side to the other. He had a lighter fall out of his butt crack. He was actually suicidal and was going to light the chamber on fire. So I don't think we have to worry about that, but you do always have to keep in mind that not everybody is like us and not everybody's in the same place. So we have to be diligent on those kind of things and make sure we don't allow anything into there that shouldn't be in there.
No.
So.
Thank you. And then shoes, right? No
Yeah.
shoes.
Yeah. Why
Check.
no shoes?
Check butt cracks and shoes.
Gas. Gas at the pumps, right?
Yes. So you could walk through gas at a gas station. We all stop there. You could have that on the bottom of your shoes, walk into the chamber in an oxygen-rich environment. If something sparks, it's gonna be not good. So in the hard chambers, you have a much increased risk. So we allow people to stay in their normal clothes. We don't make them change. In the hard chambers, you have to totally disrobe. You put on cotton scrubs. You can't have any polyester, any synthetic fabrics at all. No underwires, nothing sharp, nothing synthetic, because if it does catch on fire, that melts onto the skin versus cotton, which is not going to. So there's so many more safety parameters when you're going into the hard chamber. The one thing we have to talk about are implantables in our patients. So expanders is a contraindication. That's probably one of the more common things that we see as we're doing our post-op protocols. So breast expanders are not allowed. Pretty much everything else implantable in the soft chamber is going to be okay. Pacemakers, drains are okay as long as they don't open and close them in there. Penile implants, ports, portacaths, any kind of vascular access, as long as they don't touch it, they're fine. Colostomies are fine. Make sure they open it before they go in. Yeah, if you think of any others. So again, in the hard chamber, you can't just put anybody in the hard chamber. You actually have to go to the manufacturer. You have to look up the pressure parameters. If it's like a pacemaker, has it been tested for 2 ATA? And if so, you have a safety officer that looks at that. You have a medical officer that looks at the patient, and the two have to both clear the patient to go into a hard chamber. So, yeah. I'm gonna. Yeah.
Wound vacs, okay?
Wound vacs are going to have to be clamped and removed. So you're going to have to take the suction device, the machine off. So you just seal off the dressing, pull that off. You know how you can always clamp it?
Yep.
Yep. Just clamp it, pull the suction device off, leave the dressing intact, and then reconnect it when you're done. Yep. Good questions. Awesome. I think I have to wrap there. If you guys think of other questions, we will share this on our YouTube channel. So I hope everybody enjoyed this. This is a really fun field. It's created a lot of amazing clinical results for our patients. We're excited to have it. And with the safety of this, it's easy, it's fun, and we love it. So thanks, everybody.
Bye. Thank you.